Good morning. My name is Rami Khayat. I'm professor of medicine and psychiatry at the University of California, Irvine, and the director of the Sleep Disorders Center here in Newport Beach. I would like to thank the organizers for this opportunity to discuss the cardiovascular consequences of obstructive sleep apnea and present this to you this morning. These are my disclosures. And this is the outline I selected for today's talk. I will start by discussing the mechanism of the cardiovascular disease in sleep apnea. Then I will spend the bulk of the time going over the current literature and the data from recent randomized controlled trials regarding the effect of treating sleep apnea. And in the last few minutes, I will try to put it all in the context of clinical care and present an approach to treatment decisions based on the current data and the available knowledge in the pathophysiology of sleep apnea and its cardiovascular consequences. Before I dive into sleep apnea in itself, I would like to step back and make sure we appreciate the role of sleep in itself. So in the normal course of one night's sleep, we transition across sleep stages and sleep cycles. We experience about 4 to 5 sleep cycles, as all of you know. And these cycles consist of transitions from stage 1 to slow wave sleep and then REM sleep. And you will notice here how the REM duration lengthens over the course of the night, and the last sleep cycle would contain the longest REM period. All these almost pre-programmed or choreographed, if you will, transitions in sleep stages and sleep cycles are associated with important changes that occur in the cardiovascular system behind the scenes. Reduction in heart rate, cardiac output, blood pressure, and systemic vascular resistance are all pre-programmed to occur as we transition from lighter stage of sleep into deeper stage of sleep. These changes occur, and for example, the vascular resistance and cardiac output go down. This results in decreased work of contractility for the heart, decreased perfusion pressure on the level of the kidneys and the brain. So all these sort of expected changes would not happen, for instance, if the individual misses an hour or two of sleep. That is, the duration of decreased cardiac output or cardiac rest or the duration of decreased kidney perfusion would be less. And if someone is practicing this sleep curtailment over a 10-year period, then they are experiencing higher exposure to high blood pressure and work of contractility than those who obtain the normal amount of sleep. So this is only in relation to duration of sleep. If you imagine the occurrence of a sleep disturbance such as sleep apnea disrupting this normal transition, then that you can see how that can compound the problem. On one hand, you have the decreased sleep duration, and on the other hand, you have the decreased sleep quality and the lack of deep sleep. For example, sleep apnea results in reduction in REM sleep and the associated changes in the cardiovascular system. In addition to these immediate neurohumoral changes of sleep, there are significant cardiometabolic changes that occur in the metabolic system and in the endocrine system. For example, changes in cortisol levels, growth hormone, insulin production, and insulin sensitivity. All these things are dependent on sleep, and they have a specific circadian pattern that will be disrupted if the person obtains less sleep. So with that in the background, I'll transition now to discussing sleep apnea. And in this slide, I have what I term the anatomy of a sleep apnea. The signals we have here are a combination of those we obtain routinely in a sleep lab and those we measure in a research lab. Saturation, flow, respiratory effort. The respiratory effort here is measured invasively using pharyngeal probe or pressure transducer. And then blood pressure is beat by beat via phenopress. You can imagine it as an A-line if you're not familiar with a phenopress, but the A-line is invasive, obviously. And the sympathetic nerve activity is measured via an electrode placed in the perineal nerve level over its sympathetic branch. a very superficial branch, that is. So now if you look at this period here between these two red bars, this is an episode of apnea. There is no flow here. And along with that, there is a progressive increase in the respiratory effort. This episode of no flow or apnea is associated with immediate desaturation. And the desaturation actually takes place here, but we record it a little later because of the lag time in for the oximeter signal to travel. If you draw your attention right here, I would like to draw your attention down to the sympathetic activity, which you see the surge in sympathetic signal immediately at the time of the desaturation or at the end of the apnea. After a few seconds, we see a surge in blood pressure. And this is really the story of the night for a sleep apnea patient. It's an episode of hypoxia, followed by sympathetic surge, followed by blood pressure surge. And in between, there are these massive increases in negative intrathoracic pressure, resulting in increased transmural cardiac pressure across the free wall of the LV, resulting in increased pressure gradient and work of contractility. But importantly, the recurrence of hypoxia throughout the course of the night is associated with these surges in sympathetic activity and surges in blood pressure. This sleep apnea patient is exposed to abnormal levels of blood pressure beyond what's expected and higher levels of sympathetic activity throughout the course of the night. If we try to examine blood pressure or hypertension in itself, hypertension is the most important cardiovascular disease, and it's responsible for a significant, probably the largest portion of cardiovascular mortality, including heart failure and stroke. In this landmark study, investigators took asymptomatic individuals and put them through sleep studies, and then classify them based on the severity of sleep apnea into those who did not have sleep apnea and those who had 0 to 4.9 events per hour, 5 to 14.9, and more than 15 events per hour. They followed them over several years, a median of 4 years specifically, and looked at their odds ratio of developing hypertension here in the Y bar. And what they found was a dose effect. So the more sleep apnea events, the higher the risk of developing hypertension. The blue is the unadjusted, and the orange here is adjusted to known risk factors for hypertension. And these are listed here partially: age, gender, and BMI, and alcohol intake and family history are all risk factors for developing hypertension. So this dose effect suggests some causality in the relationship between sleep apnea and hypertension. However, if you were to attempt to study causality, the best approach would be to try to induce sleep apnea experimentally, and that obviously can only be done in animal models. So these investigators in a landmark study also took dogs and performed tracheostomy on them, and then randomized them to either receiving sleep apnea by creating periodic occlusion of the tracheostomy, or just keeping them as sham with no occlusion, but with the trach only. And they evaluated them over the course of a few weeks. The dogs that were exposed to the intermittent hypoxia or the obstructive sleep apnea pattern developed hypertension. When they stopped this periodic occlusion, the blood pressure normalized. Sham dogs who were housed in the same conditions did not develop the hypertension or the increased blood pressure. So this gets as close as possible to trying to prove causality, that obstructive sleep apnea actually produces hypertension. Taken together with that large epidemiological study I presented right before this slide, these two studies provide very strong evidence that obstructive sleep apnea is a cause of hypertension. If you look at treatment effect in or treating obstructive sleep apnea and its effect on blood pressure, there has been numerous small and large randomized controlled trials. In this meta-analysis, they attempted to group together about 16 trials that included 1,166 patients. Overall, there was a consistent effect of CPAP on decreasing blood pressure measurements, whether the systolic or diastolic. Of course, the effect is modest, 2.4 millimeter mercury and 1.83. But taken over the course of a lifetime of a patient, this is extremely consequential, because the consequences of not treating, even the consequences of what the World Health Organization terms as borderline blood pressure, the blood pressure between systolic 120 and 140 and diastolic 80 and 90, is responsible for a significant portion of cardiovascular disease and mortality. So any control in blood pressure is considered significant. And this, again, is another evidence or layer of evidence for this causality between sleep apnea and hypertension. Another way to conceptualize the relationship between sleep apnea and blood pressure is to look at the phenomena of dipping and non-dipping. Normal individuals are expected, there is a circadian pattern, as I discussed just a few minutes ago, that the blood pressure should decrease during the night. And blood pressure decrease, if you look at an ambulatory 24-hour recording here, in controls that are normals and don't have sleep apnea, their systolic should go, in the 100 to 110, and diastolic could be in the 70s or maybe even 60s range. The sleep apnea patient fails to experience this reduction in blood pressure. So to conceptualize this in the right context, the blood pressure should normally be much lower during the night or during sleep, and the sleep apnea patient is in a hypertensive range. We may interpret this erroneously as normal blood pressure, but in fact, this is actually a hypertensive range for the period of sleep. So that's one way to understand the impact of obstructive sleep apnea on blood pressure. Of course, this persistence of blood pressure in supraphysiologic range or supranormal range, perhaps not fully abnormal, will take its wear and tear on important end organs and increase the risk of cerebrovascular and cardiovascular events. So in summary, obstructive sleep apnea produces surges in blood pressure and sympathetic activity that persist over the daytime. And I didn't really present the plasticity data here that shows that the blood pressure elevation persists in the morning time. But this is linked to the intermittent hypoxia component of sleep apnea, very unique stimulus that creates memory effect in the sympathetic system and results in the blood pressure elevation persisting during the daytime. Obstructive sleep apnea is a risk factor of hypertension in large population-based studies, independent of all confounders. And hypertension can be produced in animal models of obstructive sleep apnea. Treating sleep apnea results in decreased blood pressure, and the extent of reduction, even though it is modest in terms of absolute numbers, is clinically relevant. So obstructive sleep apnea, its impact on the cardiovascular system can be appreciated importantly through its relationship to hypertension, this causal relationship and this multi-layer evidence for the relationship, that is, you can treat sleep apnea and reduce blood pressure, that you can induce hypertension in sleep apnea models, and you can see it in population-based studies. This is extremely important and consequential for cardiovascular health in the population. I'm going to move to discussing another important building block for cardiovascular disease, that is the vascular endothelial dysfunction. So endothelial dysfunction, that is the increased vascular tone or abnormality that is based on the exposure of the endothelium to stressors such as hypoxia and oxidative stress, underlies the mechanism of coronary vascular disease, plaque formation, and even the occurrence of stroke. In this study, we took patients with obstructive sleep apnea who had no known cardiovascular disease. They had normal cholesterol, no family history, no smoking, and normal blood pressure. And we looked at their vascular tone using a technique where you look at the brachial artery diameter and its ability to vasodilate. And we found that they had impaired vasodilation ability at baseline compared to group of body mass index and age matched controls, and that this vasodilation ability or the endothelial dysfunction improved once they were treated with CPAP. We then went as far as obtaining vascular tissue from these patients by performing forearm biopsies. And we looked at the expression of oxidative stress, superoxide, and the expression of the most important mediator of vascular tone and health, nitric oxide. We found that sleep apnea patients had decreased nitric oxide and increased superoxide at baseline, a pattern that reversed with treatment, indicating oxidative stress at the level of the small vessels or the endothelium, and decreased available nitric oxide, denoting impaired vascular tone and increased vascular reactivity, or impaired vascular reactivity, but increased contractility of the small blood vessels. We also looked at the expression of angiotensin receptors, and we found, again, increased expression of angiotensin receptors before treatment, which decreased with treatment, mimicking the control levels. So significant abnormalities occur. And of course, on the left here, we looked at genetic markers of vascular endothelial disease. For example, DDH and arginase are enzymes that are part of nitric oxide production. HIF1 is a nuclear factor that's induced when cells are exposed to hypoxia. So there are significant pathophysiological abnormality at the level of the small blood vessels in sleep apnea patients who do not have manifested cardiovascular disease. Of course, these abnormalities most likely will result in plaque formation, impaired vasodilation, and eventually manifested cardiovascular disease such as coronary disease or stroke. An important cardiovascular disease that is gaining relevance in the past 10 years now is atrial fibrillation. Atrial fibrillation being a silent killer. In this landmark study from 2007, individuals looked at, or the investigators looked at individuals in a large population-based study, the Olmsted County in Minnesota. They took these individuals and looked at those who developed atrial fibrillation after over several years of follow-up, and looked at the risk of obstructive sleep apnea versus no obstructive sleep apnea. Again, after adjustment for risk factors of AFib, such as weight and hypertension and age and existing cardiovascular disease. And they found that those with obstructive sleep apnea were at much higher risk of developing atrial fibrillation than those without obstructive sleep apnea. There has been several studies since then trying to understand that relationship, and I'm showing one of them here. In this study, they looked at individuals who underwent ablation, which is a procedure done, cryoablation, for treating the atrial fibrillation. And they looked at AFib patients who had ablation and underwent sleep studies. So there were those who had no sleep apnea and those who had sleep apnea that was not severe in the solid red line, and the severe obstructive sleep apnea in the dotted lines. They found, these investigators found that when patients had severe obstructive sleep apnea that went untreated, the risk of recurrence of AFib was much higher than the controls who are matched to other risk factors of AFib and recurrence of AFib. And even when they underwent a second ablation, this relationship persisted, and severe obstructive sleep apnea predicted failure of ablation or recurrence of AFib. There has been several studies since then that confirm this observation. And thus far, we know that obstructive sleep apnea is prevalent in patients with newly diagnosed atrial fibrillation, and untreated obstructive sleep apnea results in persistence of AFib or resistance to ablation, cardioversion, and medications. In terms of stroke, given the relationship between sleep apnea and hypertension, endothelial dysfunction, atrial fibrillation, these three disorders are building blocks of strokes. it would be expected that obstructive sleep apnea would have significant impact and is a significant risk factor for stroke. Indeed, in multiple population studies, there was an association between having sleep apnea and subsequent development of cerebrovascular accidents. The mechanisms, as I mentioned, are probably complex and intertwined, but again, the causative relationship between obstructive sleep apnea and hypertension, the impact of obstructive sleep apnea on the non-dipping of blood pressure during the night, the endothelial dysfunction and impaired vasodilation that we see in sleep apnea patients, sympathetic activation, and the likelihood of sleep apnea producing atrial fibrillation or making atrial fibrillation worse or more resistant to treatment. All these likely mediate this observation of relationship between sleep apnea and stroke. How about in heart failure? Of course, heart failure is an end-stage cardiovascular disease where it is hard to know where the chicken or the egg are. But in one large population-based study, we looked at about 1,100 patients with recently diagnosed sleep apnea. These patients have heart failure with reduced ejection fraction, and we followed them over a median of 36 months. And we found that those who had obstructive sleep apnea, and that's in the blue line, had much higher risk of mortality than those who did not have obstructive sleep apnea or central sleep apnea. Central sleep apnea was somewhat worse than obstructive sleep apnea, but both were important independent predictors of mortality in heart failure patients. To the right here, we have patients who were treated versus those who were untreated. And when you look at those who were treated, whatever device it is, whether it's central apnea or obstructive sleep apnea, survived more than those who had obstructive sleep apnea or central sleep apnea and went untreated. Of course, these are observational studies, but again, all fit in that preponderance of evidence to the relationship of obstructive sleep apnea and cardiovascular disease. So if that's the case, if obstructive sleep apnea is so important for cardiovascular disease, we would expect a randomized controlled trial that is done in a population of obstructive sleep apnea patients who have existing cardiovascular disease to show that treatment decreases cardiovascular events. So this was a landmark trial published in 2016 called the SAFE trial. The investigators randomized about 2,700 patients with sleep apnea who have some cardiovascular risk or disease to either CPAP or no CPAP or usual care. And they followed them for a median of about 48 months. And unexpectedly, actually, CPAP did not show any reduction in cardiovascular events. Of course, this was a composite cardiovascular event endpoint. Nevertheless, there was no relationship between treatment or no effect of treatment on reduction in cardiovascular events. So extremely surprising results. When you start diving deeper into this, you find that individuals in the treatment arm, in the intervention arm, wore their CPAP on average about 3.3 hours per night. And this was only in the initial 6 months to 1 year of the trial. Over the subsequent 1 or 2 years of the trial, the usage dropped precipitously, and only a minority of patients was actually using CPAP by the end of the trial. There were other explanations for these negative findings, and that maybe is beyond the scope of this presentation, but it is important to note the effect of usage of CPAP that qualifies these negative findings. Also, it is important when you interpret randomized controlled trials in sleep apnea to note that patients with severe sleep apnea who are very sleepy are almost always excluded from this trial, because if they are sleepy, then it is unethical to randomize them to no treatment. But these sleepy patients are the ones who are more likely to have cardiovascular consequences to the sleep apnea. The population of this study was also somewhat different. A relatively, younger population with the body mass index being not too elevated, and the majority of the patients were actually from China. whether that's generalizable or unique factor, I feel that the most important qualifying effect or factor was the fact that patients really did not wear the treatment device. The point I made about sleepy versus non-sleepy patients is underlined here. In this large trial, the investigators, this is a study that was done in Spain, they randomized patients who did not have any sleepiness to CPAP versus no CPAP. And again, looked here as an outcome at the effect on their blood pressure. They found that if you took patients who were not sleepy, you do not find much effect for treatment with CPAP on their cardiovascular disease, and in this particular case was hypertension, but there were other studies done before and after this one. Even though there was some mediating effect on post-hoc analysis that if they used the CPAP for more than 4 hours, there was some reduction in blood pressure. Of course, hypertension is the most linked cardiovascular disease to sleep apnea. So taken together, this study and the study before can be interpreted as such. If you use the CPAP for a prolonged period of time, there is going to be an effect on at least hypertension, but perhaps other cardiovascular events or diseases. But also, if you took patients who are not sleepy, you are less likely to find a benefit from treatment, whether that translates into them using CPAP less or that there's something unique about sleepiness that denotes severity of sleep apnea. Regardless, in this same trial, the SAFE trial, when they looked at the effect of CPAP, even though there was no effect on the pre-specified endpoint, that is cardiovascular, the composite, there was some effect on blood pressure, and there was some effect on sleepiness, quality of life, depression, and anxiety. So one cannot conclude from looking at a negative trial with CPAP that CPAP is not effective. It was not able to decrease the composite cardiovascular endpoint in that particular trial, but several important endpoints, such as blood pressure measurements, quality of life, and sleepiness were changed, even though these patients were not very severe at baseline. So trying to put things together here, CPAP does improve all symptoms of sleep disordered breathing, including sleepiness, insomnia, cognitive, mood, functional, driving. Of course, it decreases blood pressure, and that PAP should be viewed as a personalized intervention. It is important to keep following these patients, making sure they're actually using the CPAP. We cannot just give them the CPAP and walk away. It is important to understand how much they're sleeping, to make sure they're sleeping long enough and sleeping long enough with a CPAP on. We may be looking at the wrong biomarkers. For example, just looking at the effect of CPAP on mortality may be not the right way to understand that the effect of sleep apnea. Maybe the measurement of blood pressure in itself is a sufficient biomarker for the effect of treatment. There are some subpopulations of sleep apnea that probably would not benefit from treatment much, perhaps those who are not significantly sleepy or who have mild sleep apnea, according to more recent trials. So, in conclusion, untreated severe obstructive sleep apnea increases the risk of major adverse cardiovascular events and mortality. Effective OSA treatment with CPAP can reduce coronary events and can decrease blood pressure measurements and can improve quality of life. Even though recent RCTs have shown no effect on composite endpoints that included multiple cardiovascular endpoints, these must be viewed with caution because of the fact that patients did not wear CPAP long enough and that they included patients who were not severe and were not sleepy. I will stop here and I will be ready for questions. Thank you.